Hi, everyone, and thank you for joining us tonight. I'm Emma, and I'll be your host. Before we jump into this webinar, I would like to start with an acknowledgement of country. In the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. Just a little bit about me. Like I said, my name is Emma. I'm an embryologist at the Sydney CBD clinic. I've been an embryologist for about 4 years now and very passionate about my job. I'm originally from a small island called Mauritius and moved to Melbourne with my family. And that's where I completed my studies in embryology. I chose this field because my parents also struggled with fertility back then, and they didn't have access to treatment. So that story really encouraged me to become an embryologist, and today I'm really happy to be able to actively help people start their families. If you are new to this journey, I'd like to tell you a little bit about us, about Monash IVF. We are committed to empowering the next generation of parents on their journey to parenthood. We're here for people at all stages of their fertility journey and proud to support patients of all genders and sexualities on their pathway to parenthood. The entire team at Monash are incredibly passionate about the care and support we provide our patients. We're located all across the country. As you can tell from the map, we provide world-leading scientific and medical services. We've got clinics in Victoria, New South Wales, Queensland, as well as sister clinics in Northern Territory, South Australia, and Western Australia. For our Melburnians, I do have some good news. Early on this year, we will be opening a brand new full-service clinic in Cremorne. It's a purpose-built facility with day surgery, laboratory, consulting rooms, ultrasound rooms, everything under the one roof. And if you are from Victoria, you know that it's a very central location, convenient to get to, whether that's on public transport or otherwise, and close to the CBD. So that's very, very exciting news. In terms of the services that we provide, this slideshow gives you an idea of the wide range of services we do provide, and that's everything from fertility testing, such as semen analysis, all the way through to IVF, IUI, ICSI, egg freezing, genetic testing, and so forth. And yeah, so feel free to have a little read of that slide. On the agenda tonight, so we'll do a little bit of an introduction and we'll introduce our panelists. So Lisa Brennan will be talking a little bit about family planning, and Dr. Steve Molcheski will talk about the first steps. At the end, we'll have a Q&A. So our presenters will be answering your questions after the presentation. If you do have a question while they are going through their presentation, please feel free to press that Q&A button at the bottom of your screen, and we'll get to it at the end. And we obviously will try our very best to get to all the questions, but there's the chance that we might not get through them all tonight. However, we obviously do want you to get the information that you need. So if your question isn't answered, we do offer complimentary phone chats with our experienced fertility nurses. They can provide you with advice about what the next steps could be and can answer any questions you would have about fertility or treatment. Scan this QR code and that will take you right through booking a complimentary nurse chat. They can also help you book an appointment with one of our doctors if you're at that step. So Lisa Brennan is one of our panelists tonight. She is a patient coordinator at Monash IVF in the nurse inquiry team. She has worked as a blood scientist for over 20 years before making the switch to fertility. And she's worked for 5 years within our donor and surrogacy team in Victoria. She was a team leader there. And for the past 3 years, she's worked in the National Nurse Inquiry team, where she helps patients from all backgrounds every day. Dr. Steve Molcheski is a fertility specialist practicing on the Gold Coast. He does provide telehealth appointments to patients in Townsville. He provides his patients with holistic, comprehensive care. He was one of the establishing team. He was part of the establishing team that brought world-class IVF treatment to North Queensland for the very first time. Whilst being an experienced clinician, he now devotes his time solely to reproductive medicine. Before we jump into the panelists part of the webinar, I would like to go through this disclaimer. Whilst we do our best to be affirming, we just wanted to flag that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities. Everyone is welcome at our clinics. The information we provide in this webinar is general in nature and does not replace personalized advice from medical professionals. Please take care and enjoy this webinar.
Hi everyone. Hoping you can hear me. Very excited to be able to chat to you today. As Emma said, I work in the nurse inquiry team. My team and I are very excited to be able to take your call or receive your inquiry and to be able to share information with you. We're fertility professionals. Most of our team are nurses, and myself and another one of our team members are scientists, embryologists. So we have a lot of expertise to be able to help you on your way at Monash IVF. There are complimentary phone chats available. You can book these online via our website, or you can call directly onto our 1800 number and get to speak to one of our team directly. Phone chats really do offer support, and we aim to provide information so that you can make informed decisions about your options and build pathways. We don't tell you what to do. We're simply there to provide you with options. We've heard everything. I often hear people say to me, I've just got a silly question. There's absolutely not any silly questions. Every question is valid. And if you need the answer, we are here to provide it. And if we don't know the answer straight away, we will say, hold it, we'll get back to you, and we will. Some of our other inquiries, we will get nurse inquiries from our website. Some people will have already decided they want to see someone, so they'll put in an inquiry for an appointment. It may just be for a certain location, or they might actually want to see a specific doctor. We take those requests too. We'll chat to you if you need help choosing a doctor, and definitely you get you on your way to booking an appointment. But today we thought we'd share some of the commonly asked questions that we receive on our nurse chat inquiries. Next slide, please. It's a very common one. How do I know I'm fertile? We may get inquiries such as, I want to have a baby in 5 years, 3 years, 2 years. But I'm a bit worried. I want to make sure that in that time frame or in those 5 years, I will still be okay to have a child. And so we will provide people with information to help them work this out. One of the first things I will always find out is, where do you live? That's important, so I can start formulating in my mind who will be able to help you with your next steps. I will want to know if you're single, if you have a partner or partners. For people with uterus and ovaries, I'll be wanting to ask questions to explore your fertility to begin with. Are people getting cycles? Are they regular? Are people on oral contraception or implants? These can affect some sort of testing. What are your own circumstances? Everyone's story is different. I'm so aware of that. And I feel blessed to be able to hear your story and be able to help you. Some people will have known fertility issues. They already know they have endometriosis, polycystic ovaries, or they might be concerned because their mother, parent had early menopause. we'll explore that with them and provide them with information. It's also important for us to know your age. Age is a factor in fertility. At Monash IVF, we can treat people with eggs up to their 46th birthday with their own eggs and up to the 53rd birthday with donor eggs. To be able to know whether you're fertile or not, you do need fertility health investigations. You can get these tests done, a baseline test via your GP, or you can simply go directly to one of our fertility specialists and they will help you work out what tests are required. In the nurse inquiry team, we welcome being able to share this type of information with you so you can start exploring your fertility with your GP as your primary healthcare provider. Tests are required for all parties involved, and the results of your fertility assessments will identify any potential threats to the fertility and possible treatment outcomes and or game plan for the future for family planning. Next slide, please. This is another common question. How long will the fertility treatment process take? Some people will say, I want a baby tomorrow. How can we make that happen? Well, the length of treatment really does depend on what sort of treatment is recommended for you. As discussed in the previous slide, it's all about fertility assessments. What's going on? Is there any interventions that need to be done or further testing before a treatment plan can be determined? So key considerations to work out a timeline is what fertility investigations are required for each of the parties, counselling sessions in particular, if you're using donor components, that's mandatory, and they take time, and you do need time in between sessions to be able to think about these things. Choosing a donor, finding a donor, sometimes there is going to be a wait time for the donor that's most appropriate for you. Genetic testing, if people are choosing to use donor components, a lot of the donors will have had extended carrier screening, and so you will most probably, the gamete provider will be asked to have their own genetic screening to ensure that there's no incompatibility between them and the donor. And financial planning, money's a big factor in this. Some people will be wanting to know, how long have I got to save for this? Once you know what treatment option is open to you and is your preferred option, you will get an idea of how much, an estimate of how much this is going to cost. If you're planning on having fertility treatment in the next year or so, I strongly recommend you book a chat. If you're single, book by yourself or with a support person. If you're partnered or with partners, all join in on the call because we can share a lot of information together so you can all hear it and then plan accordingly. How much will fertility treatment cost? It's an important factor. There's a range of treatment options, and so costs will vary widely. At Monash IVF, we want to be transparent with you about costs. If you contact us in the nurse inquiry team, we're going to explain in detail on the phone possible cost depending on what you could be, what sort of treatment you'd be having. But it is challenging to provide a true estimate. You can't. Not until you've seen the fertility specialist, till you've had your fertility investigations, you've got your plan in place about what sort of treatment it is. And so until you've done that, you don't know what you need, and so therefore you won't know exactly how much this is going to cost. People who have private health insurance for IVF, it's usually the top cover. They may, you may get some of your costs back from your private health insurance. Our cost sheets that we provide do have Medicare item numbers included so that you'll be able to check with your provider what you may be covered for. The things to consider about costs, these are some different cost components. The treatment cycle fee, medications. Now, they can be costly if you're not Medicare eligible, and I'll go into that in a minute. Hospital fees. If someone's having IVF to collect eggs, there'll be hospital fees and an anaesthetist fee if you have a general anaesthetic. Most people do if eggs are being collected. There are donor fees, and Medicare does not give you any rebates for donor fees. Genetic testing of embryos, if that's recommended by your specialists, and if eggs or sperm or embryo storage costs, there are fees associated with that so that we can look after them for you in the tanks. Next slide, thanks. This is an important consideration just to be aware of in terms of factoring in costs. Will you get anything back from Medicare for fertility treatment? Your fertility specialist is the one who will determine whether you're eligible for Medicare rebates in a treatment cycle. To get Medicare rebates, your doctor needs to determine a medical need for treatment. Social circumstances alone are not a reason to get Medicare rebates. How I explained it in my chats is a heterosexual couple who have tried to conceive at home for a year or so and they've had no success, and it's been determined that they need IVF treatment or to come into our clinic to assist them to conceive, they will get Medicare rebates because there's a clear medical reason why they need IVF. People who do not have any fertility concerns at all, but due to the fact that they don't have access to sperm, they can't prove an inability to conceive, then they may not be Medicare eligible at the outset. But it's too early to tell until you've had thorough infertility investigations. I mean, there may be something revealed, a medical need that may allow you to get Medicare rebates, but it is at the determination of the fertility specialist. Things such as endometriosis, polycystic ovaries, low ovarian reserve, low sperm count, they may be examples of medical need. Next slide, please. This is actually a common question. Which fertility specialist will provide me with affirming care? People want to feel in a safe environment. Please know that all Monash IVF staff have had diversity inclusion training. I loved it. I can't wait to do it again. I learnt so much, and all our staff have done that. In addition, please note that all our fertility doctors, specialists, they're highly trained and experienced. Some of our doctors have special interests in supporting the LGBTIQA plus patients in building their families. And based on your location, we can, in the nurse inquiry team, can recommend these doctors for you. On the Monash IVF website, you may see a rainbow sort of little flag at the bottom of a doctor's bio as well. It's not I don't think it's a thorough representation, but it's a good guide there. Some of our doctors will have had the inclusion and diversity training as well. If you have a preference of doctor, some people do, please tell us and we will share some doctors for you to choose from where you live. People do call in. If for people who are wanting donor components as part of their fertility journey, they ask if there's a shortage for donor sperm and eggs. I've got a short answer, and the short answer is today. The long answer, join next week when the donor team provides detailed information about the donor program. So the short answer is that donor eggs and sperm, they are always in high demand, and demand often exceeds supply. But we do have donor availability in all our states. It depends what type of donor you want, the treatment type, and your location as to who or what is available to you. Firstly, we have wonderful partnerships with overseas donor banks. In Victoria, we have sperm donor banks, Northwest Cryobank and California Cryobank. In New South Wales, we have California Cryobank as a sperm donor bank. Central IVF and Manor Medical as donor egg banks. In Queensland, we have the sperm bank, Seattle Sperm Bank, California Cryobank. Oh, sorry, in New South Wales is also the World Egg and Sperm Bank. In Queensland, for donor eggs, they have Central IVF and the World Egg and Sperm Bank. In addition, Monash IVF, we pride ourselves on building up and having local donors available to you. We have dedicated donor teams in each state who are actively recruiting donors and supporting patients in choosing donors. We're always recruiting new donors. The state of donor availability is a bit fluid. We release new donors. Huge demand means that those donors are all taken up really quickly. and then we will bring in new donors for people to choose again. I encourage anyone who is a new patient, is not a patient of Monash IVF and wants to explore this more, join us for a free nurse chat. We will give you up-to-date information about the availability of donors, whether they be eggs or sperm in the state that you live in and other states if required, and then you'll know where you're at. Too hard to sort of share it today. Patients who are already Monash IVF patients, we'll encourage, you can absolutely call in, but we'll encourage you to speak to your local donor team, because that's what they're there for and they will help you. Next slide, thanks. So sometimes female couples, they will explore wanting to both carry a pregnancy at some time. And how does this work? In addition to the fertility sort of status questions I mentioned earlier, there's other questions that we'll need to ask. So do you want to egg share, or they might call it reciprocal IVF? Or whose eggs do you want to use? Who is the partner providing eggs? Who is the partner who will carry the pregnancy? If you want a second child, is that going to stay the same, or are you going to swap? Or the one person carries and then you use the other person's eggs? Or in contrast, are you just wanting to try with IUI as a first step? Another question that's important in this conversation is, who's the sperm provider? Is it a partner? Is it a clinic recruited donor, or is it a donor known to you who you'd like to use? We can give you all that information, supply you with pathways and detailed discussion about how this works. We'll also want to know to sort of forward plan, do you want the same sperm provider for both pregnancies? And have you both had a health assessment? Lots to chat about on that one. Thank you. Next slide. So someone may ask, we need surrogacy and donor eggs to conceive. What are the first steps we need to take? Look, this is quite complex, but we welcome your call. Please call us, book a chat, and we will find out where you live, what your own circumstances are. Do you have a surrogate? Do you have an egg donor? Or how we can help with that? Where does your surrogate live? Where does the egg donor live? Have you sought legal advice? There are different surrogacy laws and parentage laws in each state and territory. So it's complicated, but we're here to help, and the nurse inquiry team and then our donor and surrogacy teams will absolutely help you on next steps. Some people will say, you know, there's a bit happening in my life, that I've got a complex backstory, but I still want to have a child. How can you support me? Examples of this may be someone has a complex medical history. Someone has found out they're a carrier for a genetic status and they want to exclude it for their future child. The list goes on, but they're worried and they want to help. Please know that all Monash IVF staff are highly skilled in every department. We go above and beyond for our patients. We are going to advocate for you. We are going to try and provide you with as much information as we can in a comfortable and safe environment. And we focus on your needs, your preferences, and we are actively listening to what you want. In our nurse inquiry team, we want to understand your requirements from the outset. So we do ask, 20 questions, but it's all to be able to help you, to assist you in the best choice of fertility doctor that's suited to care for you based on your circumstances. And we can also accommodate preferences for the gender of your doctor, as I mentioned earlier. Some people find the fertility setting can be quite emotional, and it's challenging, especially if you don't get the desired outcome initially. Our counselling teams are here to provide additional emotional support, and I encourage that as well. Counselling is a very important part of this whole process. And you're most welcome to bring a support person with you to appointments. Sometimes having someone else there hearing another thing is really helpful, because you do get a lot of information, and it's sometimes a bit confusing to process. I'm hoping you get an idea that the nurse inquiry team is a really good first point of call into Monash IVF. As I've mentioned about 5 times, complimentary nurse chats, they are here. We cannot wait to receive your inquiry. We will call you. You can call us. We will want to reach out to you and provide you with personalised, appropriate information to help you in your next steps, find appropriate doctor, and hopefully that you can join Monash IVF as a patient and grow your family. Thank you.
Okay, good evening, and thank you for letting me be part of this journey with you this evening as well. I think you've already learned that it's a pretty complex process. There's many team players here, and I'm just one of those that work with Monash, and I couldn't do my job without just the 2 people that you've even listened to tonight. But I just want to take you through the basic journey that you'll have, and I'm happy to answer any questions at the end of it if you would like to put those forward. So just quickly going through it, what are the requirements for a pregnancy? And I'm sure a lot of you know these things, but just to go through it, obviously we need viable eggs, again, viable sperm, and then we need someone to be able to carry that embryo. So they need to have a uterus as well. So I know the people tuning in tonight have got different parts that they are able to bring to the table, so to speak. So it depends on what you are willing to use. As we just heard, you may provide the egg but not want to carry the embryo, and vice versa. So from my point of view, in part of our discussions, we'll need to find out your story and help you with your journey. So next slide, please. So the factors influencing fertility, as we heard initially, age has got a big part to play, your lifestyle, some of your genetics, and some of the fertility conditions that we'll go through. So all of these factors can influence the egg provider, also the sperm provider, and obviously then the person who will be carrying the pregnancy as well. Thank you. So what could indicate that you've got a potential fertility problem? If you've got a prior history of any sexually transmitted diseases before, these sort of things can affect tubal patency. If there's any history of, say, undescended testes, infections, which is orchitis within the testes, or any previous trauma or torsion to the testis, all of these things can affect sperm number and quality. Other conditions such as endometriosis or polycystic ovaries, as we've heard about already. So there are certain signs and symptoms that will be asked about in your initial consultations. Previous pregnancies are important. Did you have troubles falling pregnant previously? What was the outcome of those pregnancies? Then we talk about menstrual cycle, the timing, pain, and heaviness, because all of those can indicate that there are other problems occurring which may affect your fertility. Age, I'll go through again shortly, but it's got a big component to play. And then underlying genetics and medical history. There can be genetic disorders that run in the family themselves. And people have had certain drugs, hormones in their life for certain reasons, and those things can affect your fertility as well as any prior surgery that you have had as well. Thank you. So going back to the age and what it does to eggs. So at birth, the ovary has a finite number of eggs. So you're born with that number, and unfortunately, it progressively decreases with age. So the egg reserve in number and quality declines with age. So you can see the graph there just on the right. Research shows that egg quality and the quantity declines after 30, but then you get a slightly increased decline around, the later 30s, and certainly into the 40s, there's a steeper decline as well. Thank you. Same thing, the impact of age with eggs, as we said. So you get increased chromosomal abnormalities as the eggs get older. So the older egg providers are less likely to get chromosomally normal embryo, and therefore there's a higher rate of miscarriage as well in those people. Thank you. Age, unfortunately, also affects sperm, maybe not as much, but sperm quality does decrease with age. And the risk of miscarriage is higher if the sperm donor is over the age of 45 as well. So it affects both sexes, more so in females, but it also occurs in males as well. Thank you. Fertility conditions impacting eggs and the uterus itself. Polycystic ovarian syndrome is a condition that produces higher levels of both insulin and testosterone, which in themselves can affect people's fertility. If you've got blocked or damaged tubes, this can stop the sperm reaching the egg and therefore limiting fertilization occurring. And endometriosis is a condition where you get abnormal growth of the lining of the womb, both outside the womb in the abdominal cavity, and it also can occur in the muscle of the uterus itself, which both of those things can affect fertility. So these are things that we try and determine in your consultation whether we need to do more investigations for, and if present, treat them. Thank you. So some of the fertility conditions that can be impacting on sperm: low rates of sperm production can be present, or the person may have no sperm whatsoever, which is called azoospermia. That can occur both with genetic abnormalities or conditions, or you can have a blockage in the tube that runs from the testicle to the outside, which is the vas deferens. So these blockages can present from birth themselves, or as a result of some sort of surgery, even like vasectomy previously, or due to some severe trauma or infection in your life. Other conditions can be diagnosed at the time as well. For example, some people can have some varicose veins around the testicle, which can affect fertility in some people. Thank you. So some of the investigations that we may consider, there's this one called anti-Müllerian hormone, which is the AMH. That's a test for egg reserve, and I'll talk to you more about that in a second on the next slide. Pelvic ultrasound scan is not only for the person that will be carrying the pregnancy, it also is important for the person who will be providing the egg. That they may be different people, as we've already discussed. You need to have up-to-date screening, and as part of that screening, it's cervical screening if it's applicable to the person that's being treated. In infectious diseases, including sexually transmitted diseases, and immunization status such as rubella, varicella immunity. It's nice to make sure that that is up to date before you achieve a pregnancy. There's also genetic screening. There's different types of those available now. There's multi-test kits available, and Monash itself offers one of those. It is available as an in-house test, and we can certainly help you, and the nursing staff can help you and talk you through that if that's something that you would like to have. And obviously we can then do in-house semen analysis and antibody testing on that semen as is required. Thank you. So the AMH level is that anti-Müllerian hormone that I was telling you about. Some people think that it is a test of fertility. There's no such one test available. It doesn't tell you if you can fall pregnant or what the cause of the infertility is. What it does help us with, it's the best predictor of oocyte or egg reserve that you have. It's a good predictor on what sort of response you'll have to IVF. in terms of some of the numbers that we can look at. And it's also helpful for us in the dosages that we use when we set up an IVF cycle. So it's a test that we have that in our armamentarium to help us setting up a particular plan just for you. Thank you. So this just says what the previous slide says. As your AMH level falls, then your reserve goes down. Tends to happen more so as you get older, but certainly there are young egg donors that have got low AMH levels. So I'm seeing a lot more people now, as people are becoming aware of this, looking at egg freezing and conservation because they can have low numbers. And this test is something that you can just ask your local practitioner to organise for you. You don't have to see us to have this done. Thank you. This is just sort of a combination of everything that we've been talking about, some of the testing that I went through. So I don't think I need to talk too much more about that one at all. So as part of a semen analysis, there are different things that we look at when the scientist does this for us, and they're listed all along the side here. There can be problems with any component here, and obviously each one of those components adds to the functioning of that sperm. So those tests are done in-house or can be done through other private labs as well. Thank you. So as part of that, we look at sperm morphology. A large component of a normal semen sample will have abnormal forms, but we like a certain percentage to be normal, and those abnormalities can be variable. They can have, two heads, they can have funny looking tails, no tails, bent tails, no movement. So all of those things are looked at by the scientists when they do the semen analysis, and they give us an appropriate report that we can then, tell you about as well. Thank you. So when is it time to see us? I think it's a hard question to answer for one person. It's when you're ready to start a family, I suppose. But the things that you need to consider are your age. Fertility testing when you're younger can give you some information about your fertility. So as I said, I'm seeing a lot more younger people coming in now that have had an AMH level that is unfortunately already a little bit low. So you can get these investigations done now. You don't have to wait till you're trying to have a family. Your health, if there's any underlying medical conditions that may impact or you think may impact, it won't hurt to have a discussion with either one of the nurses, and they can give you some guidance on whether, yes, they think you need to be seen sooner or not. And your timeline, as we've heard, that it takes time, especially if you're looking at donors and stuff. So you need to factor all that into consideration. Surrogacy is not easy. It is quite complex. There's a lot of legal implications, which we can guide you through and help you through, but it won't happen within a week. So you need to be aware of those things. And along with all of these things, there's all counselling requirements that are part of the process. So we need to take you through those. Thank you. So in your first appointment, what do you bring? To see a specialist, you do need a GP referral to claim Medicare. Now, you can come privately. You don't have to get a referral. It's just that you won't get a Medicare rebate for that appointment. But often it's easier just to get a referral. And if you've had any prior investigations, it's nice to bring those so we don't have to try and chase those up or replicate stuff that you've already had done. What to expect? Well, obviously we have to take a history. Each presentation is an individual presentation. So we need to get to know you to try and help you through this journey. We may need to do additional fertility investigations to help us along the way. And then treatment options that are available. We may need to consider some surgery if we're considering whether there is endometriosis, or we need to look at tubal status. So that may be part of the process as well. And then we want to discuss your goal and expectations, because, you know, it sometimes may take a while, especially with donors and the counselling and that. So we need to be able to discuss those things with you, or if you need surgery first and then to get over the surgery before we can organise treatment. So we want to sit down and take you through those. Thank you. So I think that sort of sums up my discussions, and I'll hand over, and if there's any questions, we can try and work our way through them. Thank you.
Well, thank you both for this. It was a lovely and very informative webinar. So we can jump straight into the Q&A portion of tonight. So the first question, I believe, will go to Lisa. And it is, can people in WA use Monash IVF clinics for fertility and IVF? Does having to fly over east make a difference?
So it's common for people from other states, or even we do have international patients who come to Monash IVF. So we do have a sister clinic in WA, Pivot, so they could try and see that if there's any opportunities for treatment there. But yes, you could have treatment. If someone called in, and I would encourage that person to have a chat with us, because we can work out directly with them. Sort of things we'll ask them is if what sort of donor they need. We will give you information about different suppliers in different states. Someone might have, say, for example, have family in Melbourne, in which case there's the answer. Come and stay with your family and we'll support you with donors there. Someone might say, oh, my best friend lives in the Gold Coast, and we'll say, go and see Dr. Steve, that sort of thing. So we'll try and personalise that information. They can start off their appointments remotely and then just come over closer to the time for treatment. So it's possibly, yeah.
Excellent. So Steve, I believe the next one will go to you. Do you have any advice on getting pregnant with endometriosis using a sperm donor, IUI or IVF?
Again, I'd need to have a bit more information there. It depends on how severe the endometriosis is, what sort of treatment they've had for endometriosis before, what they've tried to do before. So it's hard to answer that in one sort of answer. I'm sorry. And obviously that person I'd be happy to have a discussion with to work it out a little bit better for them. But yeah, it depends on a lot of factors there.
Yeah, perfect. Now there is a question about Medicare rebates. Steve, that might go to you as well. We have some questions about Medicare rebates for LGBTIQA plus people. Could you please advise when patients would be eligible for Medicare rebates?
I'll be guided a little bit by Lisa here. You can add in at any time. I think it all comes down to whether I can say that there's a medical reason for them to have fertility treatment. If someone comes in and wants to be an egg donor for someone else and they've never tried for a pregnancy themselves, or the other person hasn't tried, and there's no other underlying medical condition, then I can't say it's medically indicated and there won't be any rebate for it. So again, it depends on the story of the people that I'm seeing and whether there is actually something that I can tick that say this person is infertile for a medical reason. And that is like if they've got blocked tubes, if they've got a history of endometriosis, or we actually would then investigate if they are found to have endometriosis. If they come, say, someone comes in with painful periods and then we go on to do a laparoscopy, we find some endometriosis, then we can say, yes, there's a medical reason. Or if someone is not ovulating and we find out that they've got polycystic ovaries, then we can tick that. But if there's no medical reason, then I can't tick the box that says that they're eligible.
Steve, it is for both. If it's a couple, it's for you're taking into account both partners.
Yeah, it would have to be both people as well. Yeah.
So I think that kind of answers the second question, maybe not, but it's along the same lines. Would the Medicare rebate consider medical fertility problems of the couple or only the person carrying the pregnancy? I.e., the person who will carry has no fertility problems, but their partner is transgender and taking hormones that have impacted their fertility.
So, sorry, can I just see what, can you repeat that part of it again?
Yeah.
Sorry.
So the person who will carry has no fertility problems, but their partner is transgender and taking hormones, and that has implicated or impacted their infertility.
Impacted their fertility in what way, I suppose? Is it because they're not producing sperm? The partner is it's going to be the sperm donor. Is that what we're implying?
I believe so. So yeah, taking hormones and would have then impacted their fertility. Yeah.
It sounds like you need more information. So like,
yeah,
someone preserve eggs or sperm prior. There's lots to it,
I think I'd probably like that couple to ring in so we can find out a bit more detail. I don't want to give sort of wrong advice when I don't know the full story there.
It's too hard to answer that.
Yeah.
Yeah, sorry about that. But if we get more information, then we can certainly try and work that out for those people.
Yeah, I think this is one of those cases where this person would benefit from the complimentary nurse chats as well. So whoever you are, if you ask that question, please remember to use that QR code and be able to book in a chat so we can help you in more detail. So the next question is, are we allowed to use our friend who wants to be a donor?
A donor of what? Our eggs or sperm? Do we know at all?
No, we don't know in this instance. Would that affect?
Well, I suppose just quickly, for people who want to use known sperm donors, there is a quarantine period and that is 6 months. So if they have to go through it, and you as the embryologist may be able to answer that for them yourself. So I'm sure you can.
Yeah, look, we definitely have had people, more so with sperm, known donor, whether that be a close friend. But yeah, so there is that quarantine period just to make sure that everything is safe, and then we can use that sperm. We've also had instances where we've had close friends act as surrogates, but it's the same story. We do have to make sure to keep everybody involved safe, that we follow the quarantine periods and follow all the protocols involved.
I could put my donor hat on for the minute and say, like known sperm donors, known egg donors, very common. In particular, if it was a known sperm donor that they're mentioning, the patients need to see a fertility specialist. Their donor will most probably need to see the fertility specialist. Well, the fertility specialist needs to know about that donor because it's the sperm provider for their treatment. The known donor will have medical investigations and make sure that they're medically suitable as a donor. The sperm quarantined. There's infectious diseases screening, genetic screening from the donor. The donor and their partner, if they have one, must consent to Monash IVF and undertake counselling. The recipients have counselling, and then they have shared counselling. So it's quite detailed, but very important to have all those steps. And the quarantine, actually, I think, well, it depends. In Victoria, it's 3 months, so say 3 to 6. But it's a longer lead in time, and you can't waive any of those steps along the way.
Yeah, thank you for that. The next question is directed at you, Steve. Could you please talk about the impact of cervical polyps on fertility?
Cervical polyps themselves shouldn't affect fertility in any great deal, and unless it's very big, a cervical polyp itself. So I can't remember the time that a polyp on the cervix itself has impacted. Uterine polyps are a little bit different, and I'm not sure if it is actually, if that person means a uterine polyp, but if it's an actual cervical polyp, then it shouldn't be affecting fertility to any great deal. And they're easy enough to be removed as well. A cervical polyp can quite easily be treated, so that person can be seen by specialists and have that removed, no problems.
Next question is, what is an IUI? Could you please explain this process? Again, I think, Steve, that one is directed at you as well.
So IUI is intrauterine insemination. So the person who will be carrying the child will, most of the time we monitor their cycle. So at the time that they should be ovulating, we'll have a sperm sample that will be prepared by the embryologist, and that'll be inserted with a very tiny catheter. It's like doing a pap smear, where we put that speculum inside, put a little catheter through the cervix into the uterine cavity, and then deposit the sperm sample. It's done while you're awake. There's normally minimal discomfort with the procedure. So, yeah.
Yeah, perfect. So our next question, Lisa, I think this one is for you. I don't have a regular GP. How do you suggest I get a referral to see the fertility specialist?
That's a tricky one because we don't, Monash IVF, we don't have our own GPs. I don't know whether Steve can answer. I usually say to people, it's very important to have a primary healthcare provider, wouldn't you say, Steve? Like, it's for them to go back to.
Oh, sure. I think that's important for anyone. You know, nowadays I'm getting referrals for people. There are the telephone numbers of GP services that you just ring up with a problem, and I've had a couple of referrals from those, and they're very straightforward. Please see this person for this problem, and I got no other information because they don't have any other information. But I suppose if you're desperate and you can't find any GP at all, there are those services. Certainly in Queensland, I can't speak about the other states themselves, but I think even some of the 24-hour clinics and bulk billing clinics, if you go and see someone there and just explain your situation, it should be reasonably easy enough to get a referral to see a specialist wherever you want to.
I say to people as well, if perhaps ask a friend or someone who lives close by, who do they see? Do they have a positive experience with a GP clinic, and then go and see them? The other important thing to note is, if you do have a GP referral, when you see a doctor like Dr. Steve, that allows you to get a Medicare rebate from the consult fees as well, which is helpful for money.
Perfect. So what is the approximate timeline from first appointment to conception using IVF, if conception is achieved in the first round? Steve?
Well, again, it's difficult because it depends on how many investigations you need to lead up to that. But I think what they're trying to apply is, if we start a treatment cycle, what happens? So if we decide that we need to go to an IVF cycle, say, and I'm just speaking broadly here, with all the investigations and everything being done first, we wait for your period to start, and on about the second day, the nursing team teach you how to give yourself some injections, which last for about 10 to 12 days. We'll do an ultrasound scan roughly on about day 9 or 10 to see how many and what size the follicles are. And from that, we can work out which day to actually go and collect the eggs. And that can be done within the next 4 or 5 days. Fertilization then occurs in the laboratory. And then once fertilization occurs, we grow those embryos for 5 days to what we call a blastocyst stage. If they reach blastocyst, we know that gives us our best opportunity of success. And then that can either be put back in as a fresh embryo, or what sometimes happens is that we say, because of some of the hormones, we stop that cycle, we freeze the embryos and put it back in a subsequent cycle. But that whole process gets done within a month, basically. So, yeah, so once you start the cycle, you'll have your pickup, you'll have your fertilization and the blastocyst formation within the month.
I'll add to that, just in terms of just people to keep in mind, you can't always see a specialist within a week or so. We've got a huge number of amazing specialists, but their wait times do vary. Some people have very long wait times, so you also need to keep that in mind. So to be proactive, to book for your preferred specialist so that your timeline, it fits your timeline.
Perfect. Another question here is, does Monash IVF assist in finding a surrogate?
No, you need to bring your own surrogate.
All right, perfect. Now, sorry, I'm just trying to find another question. So, female couple with known sperm donor, at what part of the journey do we include him in our appointments? And that one.
So are they looking at bringing a sperm donor? Is that their question? Or
they have a sperm donor, they have a known sperm donor. They're just wondering when to include him in the appointments.
well, obviously we'll see all of them really, I suppose, straight up, because obviously if he's going to be the sperm donor, it has to go through that quarantine period. He'll have to go through the investigation. So we would like to get him involved. He'll have to have a separate referral from a GP to be seen and be part of the process as soon as we can, because obviously, as I said, there's the investigations, the quarantine period to be sorted out.
Perfect. We do have a question here directed at both you and I, Steve. What is ICSI?
Well, you're the expert at ICSI. I could talk about ICSI, but you do it. So I think, how about you go for it?
So yeah, maybe I can talk about what ICSI is, and you can talk to us about why you would recommend ICSI over IVF. So
okay.
ICSI is essentially when I would select a sperm and inject it directly into the eggs, as opposed to IVF, which is a bit more of a natural process where we have the eggs and we have prepared sperm. Obviously, we have very strict criteria, to choose whether or not the sperm is okay for IVF on the day. But the sperm will swim naturally to the egg. With ICSI, doesn't matter if we have a lower concentration of sperm, or even if it's a good concentration of sperm, we will strip the eggs of all the surrounding cells, assess whether they are mature, and then inject them.
Okay, so going to why do you need one or the other one? ICSI is used for people more often than not than if they got poor sperm quality, and that can happen in any of those 5 listed things that I went through, whether there's a lot of abnormal forms, whether the count is very low, whether they're not moving very well. So all of those things can impact sperm quality. So if we get a sperm report that shows that there are defects in the sperm sample, then we may recommend to do the ICSI process. Another thing that happens, and certainly it's happened to all IVF specialists, if we just do plain fertilization, just mixing them together, then we've had repeated failures where there's been no fertilization. We come back the next day, the eggs and sperm, even though they look normal to us on our grading processes, there's been no fertilization. So there is something in that fertilization process that we don't know the answer to, and it just hasn't worked. So therefore that cycle has failed. And then in repeat cycles, we recommend to have ICSI performed. And it can be ongoing in cases where we're collecting eggs and they're precious eggs. Every egg is precious, but especially in the egg donor, if they're older and we're only getting 1 or 2 eggs, then sometimes we will say, well, hey, let's try and use ICSI just to improve our fertilization rates. It doesn't always go hand in hand. So that's another reason. So there are multiple reasons why we may recommend ICSI. And again, they would have to be discussed with you.
And sorry, just cut in there, if you're using a clinic recruited sperm donor and not for IUI, then the preferred technique is ICSI as well.
Yeah.
Best for trying to get best outcomes.
Yeah.
So in general, ICSI tends to get us a better response. But if the sperm is normal, eggs are all normal, then it probably doesn't help in those cases. But in the more difficult ones, yeah.
Perfect. Now, Lisa, I do have one for you. how many sessions of counselling is mandatory?
It does vary state to state. So there are state guidelines. In Victoria, any type of IVF treatment, egg preservation, egg freezing, IUI or IVF, I think there's at least one session. If there's any donor components, and it depends, if you're using a clinic recruited donor, I believe it's 2 sessions minimum of. If it's a known donor, then as I mentioned earlier, there's 2 sessions for the recipients separately, 2 sessions for the donor and their partner if they have one separately, and then there will be at least 1 group session. It is at the determination of the counsellor to make sure everyone feels comfortable and everyone's on the same page. In the other states, I believe, I'm not quite sure whether the patients need to have counselling for IVF. I think the doctors do good consultation there, but any donor components, there'll be donor counselling. In New South Wales, I believe it's 2 sessions. In Queensland, I believe it's probably a minimum of 1. It does depend. Depends what people need as well.
And these are legal requirements as well.
Yes.
We can't get around that. Yeah.
Yeah. It's important though. It's supportive as well as informed consent. If the outcomes aren't as expected, you've got a few extra things in your mental toolkit to get through this, in my opinion.
All right, thank you. So the next question, Steve, this one goes to you. Is there a medical rebate for male couples using a surrogate?
No, I don't think there is, as far as I'm aware. Do you know the answer to that one, Lisa?
I don't believe surrogacy gets any Medicare rebates. Don't quote me on that. But I don't believe so. If you ask for a chat, ask that question in that chat and we'll make sure we've got the answer for you.
Yeah, definitely. What kind of support is offered for solo flyers with no family support or friends? Mental health is more important than ever post-pandemic. So what arrangement have you considered, or have we considered as a company, to accommodate? Lisa, I think that one might be.
So it's people becoming a solo parent by choice?
Yes, and the kind of support that we offer.
I do regularly get inquiries from people who describe themselves in that way. We treat all our patients the same, so everyone does, regardless of whether they're single or partnered. So there are great support mechanisms in place. As part of the counselling in the donor sessions, as I say, the counsellors will be digging into your support networks, how you feel, how you're going to tell your future child that donor conceived. There's a multitude of reasons. What was the question again? Sorry, I just lost my train of thought there.
Just the kind of support that we would offer to.
Oh, right. Sorry. Yeah, thank you. Back on track. People do mention, and I'm not sort of promoting this, but I am aware, if you Google that solo mother by choice or solo parent by choice, I think there's really extensive support networks out there, Facebook groups, but the counsellors will mention that as well. And that's another part of it, to help you through this part. And you're not alone. And we're here to chat for that first step.
And I think this is where it's important to have a GP that you can rely on as well, because obviously when you're talking about mental health, and sure, mental health is a big part of our world today, and IVF is even a worse journey with regards to that. So it is important to have your first base medical provider that can help you with that, because certainly we're not experts in that field, while general practitioners are much more qualified to help you along that journey.
And just to know that if people are thinking they're alone in this, they're not. Talk to people every day who are going, and Steve would too, going solo on this journey. So yeah, it's normal.
What is the success rate of IUI for someone in their early 30s?
Again, it's a very broad question. It depends if there are any other underlying medical conditions involved. And, you know, as we were saying, polycystic ovaries, endometriosis, and that as well. So, yeah, it's a hard question to answer, giving a definite number to that answer. I'm sorry.
There are some success rates on our website. I don't actually know if it mentions IUI though, Steve. There's definitely IVF, and there's a natural conception calculator.
Yeah, well, we know, obviously, and just go through it quickly. In a heterosexual couple that have got no medical other problem that we're aware of, it can take up to a year for about 85% of the population to fall pregnant. So it can take someone who's ovulating on a monthly basis, having regular intercourse. Yeah, it can take up to a year for that person to fall pregnant. But yeah, so if you're doing IUI, then if you're saying you've got no medical problems and you're using normal sperm to put the IUI in, then obviously it could take up to a year for you to achieve a pregnancy the same way. So so if you're saying, well, what's my chance each time? It's probably about 10 to 20% chance, you know, working along those lines.
Perfect. Thank you for that answer. Steve, the next one's actually for you again. Is it possible to have fertility testing done if you have an IUD in place?
Yeah, certainly. Your IUD won't affect your ovulation or your hormone levels to any great amount. AMH levels can be done with an IUD in place. So we can do all of those with an IUD, yeah.
Perfect. Lisa, the next question is, as a lesbian couple who needs sperm, if we get sperm from another state, do we need to travel to have treatment there as well?
Yes, absolutely. Donor laws are state-based. They differ state to state. We can't really move donor sperm from state to state to help people. You do need to come to the state where you're choosing to use that sperm donor, because that donor has been consented and counselled to that state's legislation. There's probably a longer answer to that, but yeah, yeah.
Short answer, yes.
But as I say, in some, depending on where you live, because we do have international patients coming through, there can be some, the starting process can be done remotely, and then you come closer to the time to start treatment. But you will need to be here for a period of time, especially if it's IVF.
Yep.
You have to commit to some travel.
Now, Steve, this question is about it's from a lesbian couple. They're wanting to start a family in the next 5 to 7 years. Is it too early to start investigations?
How old are they? Have we got any idea?
We don't know that. We just know that they're wanting to start a family in the next 5 to 7 years.
I suppose it then boils down to how their age, I suppose, who's going to be the carrier. Are there any other medical conditions? Have they had any prior problems like ovulatory disorders, endometriosis? So again, I'm sorry, I keep on going that it's hard to answer one individual question, but I certainly think doing an AMH level, because they're looking at one of them being the egg donor, I would presume. So it depends on the person who's going to be the egg donor. And then obviously the person who's going to be carrying the pregnancy, what are their age, and are there any underlying problems? So I think it certainly wouldn't be a bad idea to go and see someone at least, you know, they even a baseline, if it's a GP, and say, hey, do you think there's any issues going on? Because as I said, if the person going to be the egg donor is already 35, and I'd say definitely you need to do something straight away, even if that means preserving eggs and going through a cycle and preserving some eggs for the future. So there's a lot of variables again to answer, or a question and then answer in that question.
We do speak to many people every day exploring egg freezing, and there are people who are, you know, from 28 onwards who are asking about this, and it's in a similar vein to that, Steve, is that if some people are quite concerned and worried and they really need to know, and so we encourage them to see their GP, have some fertility tests, and possibly I strongly suggest seeing a fertility specialist as well to know exactly where you're at, and then you'll know how long you've got. Yeah, in a way. Is that same fair, Steve?
Yeah, there's a lot of variables, as I'm trying to allude, and especially then when you got two people involved there that will be sharing things, it can compound the problem. So I think it's worthwhile, if they can't see a GP, just to ring someone like Lisa first of all, and she can try and answer that once she gets a bit more of a history of what's happening, you know, and that. So please just give us a ring and discuss your case individually. It'll give us a better idea how to answer that for you.
Some stories or history will jump out to us to say that sounds like you really need to see someone sooner rather than later. Other ones will be, you could wait, talk to your GP. You know, everyone's got their own story.
Absolutely. So jumping on to the next, Steve, I believe this one might be for you again. So are there specific STIs that have a detrimental effect on fertility in people with uteruses?
It's more those that can damage some of the anatomy, and the classical ones are things like gonorrhea, chlamydia, and that. So those ones will have definitely the potential to block tubes and therefore infertility because of that reason. Certainly any one of those can cause major pelvic infections, therefore can then affect the ovaries if there's a lot of scar tissue involved as well. So it's any one of those major sort of STIs that we talk about, is like the chlamydias, the gonorrheas, the syphilis. But other things can cause major problems. It's less likely. So it would depend on how severe the pelvic infection was.
Yeah, excellent. Now, Lisa, the next one is for you. What are the waiting times for appointments like when you have a referral? Is it similar to some of the other medical clinics when you have to wait several months for an initial appointment?
So it depends where you are, where you need to see a doctor. I would say with Dr. Steve at the moment, you could probably see him within a couple of weeks, if or so. We keep note of all the doctors' wait time so that we can be open with you, and I'll share that information with you. In general, doctors' wait times vary from about 2 weeks to 10 weeks. There are doctors who will have a longer wait time, but you know, some people want a specific doctor to see, some people will want to see the soonest one. We will share that with you. So we can absolutely find in a shorter period of time get an appointment for you with appropriate doctors, but it does depend where you live. If you're in a remote location, one of our regional centres, then there may be a longer wait, but we'll be very open with sharing that information with you.
Excellent.
And a lot of us will do Zoom sessions. So if we're available, we can do a lot of stuff initially on Zoom like we're doing, and we've learned from COVID, we can do a lot that way. So, but again, some of the more established people that have been in clinics, and some doctors don't only do IVF, some doctors are doing other gynecology, even some are still delivering babies. So sometimes obviously they have less time frame for their IVF component of it all. So there's different vary. Reasons.
Yeah, and you're right. Some doctors are doing remote, doing video consultations continuing. Others are face-to-face still. So it varies, but we will definitely be able to share all that information with whoever's interested. Book an appointment in terms on our website.
Yeah.
We'll call you.
So we're down to the last two questions. So the first one might be for Steve. My GP said that fertility investigations can't be done until you have been trying to conceive with no success for over 12 months. Is this true?
No, you know, if you wanted an AMH level, say, you can go and you should be able to go and ask for that, no problem. So, you know, that's not the only infertility treatment, but again, it varies with age. If you're, you know, already into your 30s and you've been trying for 6 months, then I would already be offering investigations for people just to rule out. And some of those things just involve blood tests, a semen analysis, and they're all very low key. There's no major component to it. So I think if that GP is saying that, then I would just find another GP, because you can certainly have those preliminary investigations a lot earlier.
Yeah, perfect. And Lisa, the last question might be is for you actually. So, do both members of a couple need a referral?
Yes.
Yeah.
Well, Steve's nodding too. Yes. It's when you're coming as in a partnership, it's a shared journey. Sometimes people get sort of distracted by there's one person having treatment, but both need to be on the referral.
Excellent. Well, thank you for joining us. That's all of our questions tonight, so all of the questions for tonight. Thank you for joining us, and to all of our presenters, thank you for sharing the knowledge with us. If you did have a question that we didn't get to, please again scan that QR code to book a complimentary nurse chat with one of our experienced fertility nurses, and they'll be able to offer personalized guidance about your options. Dr. Steve Mokcheski is available for appointments on the Gold Coast, like we mentioned before, and for Townsville patients by telehealth. He would love to support you on your fertility journey, so feel free to book at your earliest convenience. We hope that you will join us during the next week's webinar in this series, donor treatment options for LGBTIQA+ patients. That will be on Tuesday, the 28th of February. Thank you all for attending. I wish you all the very best on your journey. Have a good night.